medical campus of Hiroshima City, located on central of Hiroshima City, actually Kasumi area. This is a medical campus, and but unfortunately far from main campus, about 40 kilometers. So third floor of this building is dental clinic. So we have a dental school and accept many of the students from abroad, including Airlangga University. We have 4- and 5-year international programs, so-called IDC, and accept every year the 3 students from each school. So very close to the main Kasumi campus, we have baseball stadium. The Hiroshima Cup is very famous. And in a holiday, so we'll go to the stadium to see the baseball game. So let's start my lecture. So today, I would like to talk about preventive and interceptive orthodontics. So orthodontic treatment is classified into 4 types: preventive, interceptive, and limited, and extensive corrective orthodontics. Today I focus on the preventive and interceptive orthodontics. So to think about the prevention of malocclusion, we have to know the malocclusion is a multifactorial disease. Actually, so many factors to cause malocclusion that develop in close association with genetic and environmental factors, acquired and genetic factors, not a single etiology. In case related factor to malocclusion is obvious, onset or increment of malocclusion can be prevented by exclusion of the cause. So we have to know the cause of malocclusion. So the congenital or genetic factors, I want to talk about the factors, congenital and acquired factors today. So malocclusion, this one. The congenital cause, there are a lot of congenital causes. The famous 11 disease caused by mainly genetic factors. So the etiology in Japan, the most popular congenital disease is cleft in oral area is cleft lip and or cleft palate. 1 in 500 in Japanese. But in many cases, it is not clear about the genes that directly affect malocclusion. We have a lot of knowledge about the mutation of genes, but detail is not clear to the relationship between malocclusion and mutation. So we have to study more about the clinical and basic study. So we are now studying about the functional analysis of possible responsible genes to jaw deformities. So I will introduce this research. So this is a picture, a famous picture in the Spanish people. So Maximilian first is a father. Actually, he is a king, and Maria de Bourgogne is his wife, and he had the 1 children, Prince Philip, and also he has 3 children, Carl Phipps and Carlos first, and Carlos first had 4 children. Leopold 1 and Philip 2 and Philip 3 and Philip 4. So actually, all of the family members has skeletal malocclusion, mandibular protrusion. So Philip 3 and Philip 4 has children, Prince Margarita and Carlos 2. They also have mandibular protrusion. This, obviously, they have some genetic factors to cause mandibular protrusion. So from this knowledge, we try to find the responsible genes to cause mandibular protrusion. Actually, skeletal mandibular protrusion. She is a young female with probably skeletal mandibular protrusion. And her family member also had mandibular protrusion with red colored. So square means a male and round means female. The family member, all family members has the genetic factors probably, and so far we don't know that this genetic factor is dominant or recessive. If they have dominant inheritance, we can guess like that. If the factor for jaw deformities were positive, it's color red. Negative, white color. So if in the dominant inheritance patterns, if either of the parent have the factor of mandibular protrusion, the children become the mandibular protrusion about 50%. And her elder brother doesn't have mandibular protrusion. So if we compare the she and her brother carefully, we'll find the genetic factor. These are the different sister family members. They are sisters, and also both had a mandibular protrusion, very similar occlusion. And her family members are like that. This is a little bit complicated. So we can guess this seems recessive inheritance. It means that both if they have the positive factors from parents, both parents, they will have a mandibular protrusion. So we can compare between the family members, sisters, brothers, and we can also find the genetic factor. So to find the genetic factor, next generation sequencer is very useful to compare 4 gene genome of them. So we tried several times. So far, we had a lot of candidates, but we cannot focus on one or several genes. We have to have more family members to have mandibular protrusion. This is very hard to know the genetic factors. So there's several other acquired causes, like systemic cause. The typical systemic cause is endocrine disorders. Pituitary gland disorders have microsomia and acromegaly. This disease causes the overgrowth of mandible, oversecretion of growth hormone before closure of growth plate in long bone cause macrosomia, and oversecretion of growth hormone after closure of growth plate in long bone cause acromegaly. This is a very similar but different disease. That causes skeletal mandibular protrusion. And a different endocrine disorder is thyroid gland. In the systemic hypergrowth and delay in tooth erection due to delay in tooth formation were caused by impaired secretion of calcitonin by thyroid gland. And acceleration of systemic growth and early tooth erection is caused oversecretion of calcium from thyroid gland. From thyroid gland, the abnormality in thyroid gland cause different disease. The impaired secretion of parasite hormone cause hypercalcemia and enamel hyperplasia. And oversecretion of parasite hormone cause hypercalcemia and osteoporosis. So different systemic cause is a nutritional disturbance. Typical disease is rickets caused by insufficiency of vitamin D and ultraviolet rays. This disease causes malocclusion by hyperplasia of tooth enamel and microdont and malformation of tooth crown. Also delay and abnormal position of tooth eruption. So either way, treatment of systemic disorders leads to fundamental prevention of malocclusion. Effective approach to the systemic disease before treatment of malocclusion and to have a result of suppression of deterioration. So let's focus on the prevention of malocclusion in primary dental stage. The most malocclusion in the primary dentition do not affect permanent dentition. Even orthodontic treatment is not started at this age. So we cannot rush to start orthodontic in many cases. But in several cases, we have to start orthodontic treatment in primary dentition stage. For example, space maintenance of dentition is needed. In another case, early treatment of functional shift of occlusion is needed. And early treatment of relationship between upper and lower jaw, the severe mandibular protrusion or maxillary protrusion. And also elimination of all habits. This is very important to prevent malocclusion, to retain the space for tooth eruption of permanent tooth. Treatment of dental caries is also important. And removal of cuspal interference is very important, probably caused by mandibular protrusion. So, and also occlusal adjustment of occlusal interference site is needed in such case in primary. In primary dentition, it should be okay. The activator can be used for the improvement of mandibular shift. And this relationship of primary dentition can be diagnosed by terminal plane. We can know the tendency of jaw relationship by terminal plane. So from terminal plane, if we diagnose terminal plane distal medial step type, we guess the mandibular protrusion in the future. Anterior crossbite, including bilateral primary canines with medial step type terminal plane, very likely to become skeletal mandibular protrusion. So we can start orthodontic treatment earlier, and also. Anterior crossbite, except primary canine with vertical step terminal plane, may recover during mixed dentition. We can wait without any treatment in such a case. Regarding the oral habit, we have to worry about the open bite. So removal of relevant oral habits are very important. The treatment for the treatment method, we have several choice, like some store and tongue clip, and some kind of training to eliminate the oral habit. If the patient have deep bite or disc occlusion, generally just observed without any active treatment in primary dentition stage. It's too early to start to improve such kind of malocclusion. Generally, treatment will be started in mid and jaws should be improved to prevent the abnormalities. One, skeletal discrepancy, one, dental factors, and others oral habits. For skeletal discrepancy, we'll worry about functional or skeletal mandibular protrusion and maxillary protrusion, cross bite, open bite, and deep bite. All kinds of skeletal discrepancy will be treated in this stage. And dental factors, anterior crowding, excessive overjet, malposition of tooth. This kind of abnormality will be caused by dental factors. And relevant factor is oral habit. We have to remove tongue thrust, finger sucking, or all kind of oral habit. Interference, occlusal adjustment, mainly in primary tooth or tooth movement for permanent teeth, and oral habit, removal oral habit. That many kind of appliances can be used. And other etiologic factor, the management of abnormality in tooth size and morphology can be considered. The supernumerary tooth, in many cases, supernumerary tooth cause malocclusion. The center of the incisors showing in the picture, the diastema. In many cases, diastema caused by a supernumerary tooth impacted in center of the upper dentition. Also, in the opposite case, spaced arch do work. In many cases, spaced arch were caused by micron or missing tooth, like the congenital missing tooth called spaced arch. And so, managing also early tooth eruption cause malocclusion. So, management of persistence of primary tooth. Actually, we have to remove the primary persisting primary tooth. The picture shows a ring version of upper left central incisor caused by persistence of primary incisor. So, delay in tooth eruption. The panoramic X-ray shows that many impacted the canine and molars. This kind of the delay cause malposition of tooth birth and deficiency of available space, arch space for eruption, and also malposition of tooth eruption, such as dislocation, torsiversion, and transversion. So in such case, we have to think about the space maintenance. Insufficiency of eruption space for successor permanent tooth caused by early missing or the impacted tooth, we have to have some appliance to maintain the space. Usually, we use crown loop or bundle loop to keep one one space, one teeth space. And also, a lingual arch can be used to keep the full dentition. And in many cases, also malocclusion can be caused by cyst formation. We can find cyst by X-ray images. I will show one case with malocclusion caused by the cyst, follicular cyst. She was introduced by the private orthodontic clinic, and she already had braces in her teeth to align probably the anterior teeth. However, she had impacted canine on the both sides on the upper dentition. The impacted canine caused the root resorption, the central incisors, and probably the lateral incisors, the upper dentition. This is a very difficult situation. So we first think about to pull out the upper canines to rescue the upper incisors. So CT images show the obvious root resorption on the right side of central incisor. So we use lingual arch to retract the canines, impacted canines. We need surgical assistance to attract our canines. So after a treatment, successfully canines are adapted. But root resorption, for root resorption, we cannot anything right now. So the other thing is impacted tooth or the follicular cyst can be found in early stage before starting to at least before starting to orthodontic treatment. So let's go to another factors: abnormality of tooth eruption by odontoma. So you can see the yellow lined area. There are so many small tooth-like structure on the panoramic X-ray. This is odontoma. This disease causes many of impacted tooth and malposition of the permanent teeth. So one possible approach is surgical removal of odontoma. So prolonged retention of primary tooth and osseous ankylosing of tooth, dentist probably can easily remove these factors. So we have to think about that. Then loss of permanent tooth, we have to think about prosthodontic treatment or the second phase treatment with brace. So on the oral habit, so such as long-term use of teething ring or finger sucking, tongue biting, tongue thrusting, mouth breathing, or abnormal swallowing habit. Actually, so many habits to cause malocclusion. So oral habits that adversely affect dentition are basically removed as soon as possible. So abnormality of frenum also cause the space. Maxillary frenum, lingual frenum, will cause the diastema or the abnormality in tongue movement. Also, lip biting and lip sucking like that cause maxillary protrusion. So actually, she had the lip biting and some sucking, and finally, she had very severe maxillary protrusion. Actually, he had 11.4 millimeter overjet. Overbite also abnormal 5.1 millimeter. So for him, skeletal discrepancy is also severe. Actually, NB angle was 7.5 degree. She was still young, so we tried to activate her to improve the procline of upper incisors and also skeletal relationship between upper and lower jaw. So after 11 months, his occlusion dramatically improved. Molar relationship became angle class 1, and overjet and overbite became also normal, unless very rare case. Such improvement was attained by single activator treatment. Overjet became size 3.5 millimeter, overbite became 2.5 millimeter. So, open bite is classified into alveolar and skeletal open bite. Removal of oral habits such as tongue habit, finger sucking, and orthopedic force applied for the treatment of alveolar and skeletal open bite, respectively, especially for open bite, removal of oral habit is very important in early stage. I will show another case. She was 10 years old female when her first arrival. She had open bite, probably due to the tongue thrust. She had the 3.2 millimeter overjet and minus 2.1 millimeter overbite. The both molar relationship was angle class 1. So we can see the tongue between the upper and lower incisors here. So cephalometric analysis show the protrusion of upper and lower incisors, probably due to the tongue thrusting. So in such case, we will use appliance or some way to eliminate tongue thrust. So this time we selected the use of tongue thrust to remove the tongue habit. In this case, we use removal type. Usually, the tongue clip was fixed on the upper dentition. Thereafter, 11 months treatment with tongue clip, her overbite were improved dramatically, like that. So in this case, obviously tongue thrust cause open bite. So removal of open bite naturally improved the situation. So when she was 12 years old, her occlusion looks almost normal. And the angle of 2.5, and her incisors looks very good. So the main purpose of the orthodontic treatment in mixed dentition stage is to exclude factors which disturb the growth of dental arch and jaw, as well as improvement of the relationship between upper and lower jaw. This is a kind of prevention of malocclusion and or interceptive purpose of orthodontics. And there are four main purposes: improvement of A and B angle, and the establishment of angle class 1 molar relationship, and improvement of abnormality of overjet and overbite, and cancellation of crossbite. The cancellation of crossbite is very important among them, because the molar crossbite will cause the further severe malocclusion, skeletal malocclusion. So I will show a case. He was 11, almost 12 years old, boy, with chief complaint of crowding of anterior teeth. He and his parents worry about the crowding. They didn't notice the mandibular deviation to the left side. Actually, his midline of the upper and lower dentition was not matched. So, it caused mandibular deviation, skeletal mandibular deviation. If we take central frontal cephalometry, we can see mandibular deviation. Maybe a very small deviation, but if we didn't do anything, the deviation became more even worse than this stage. So in the panoramic X-ray show the impacted upper median supernumerary tooth. Probably this causes the malposition of the upper left lateral incisor. Maybe cause a crossbite of the anterior region and cause mandibular deviation. Here, we can see the crossbite on the left side incisor area. This occlusal interference causes mandibular deviation. In case it's a primary dentition, we can have the grinding or the extraction of primary teeth easily remove the crossbite. But in a permanent dentition, we will not select this kind of choice. We'll improve this situation by orthodontic tooth movement. We used linear arch to just remove the interference of lateral incisors. This cause, and also we extracted impacted supernumerary tooth, and the gap of midline was improved quickly. So there are so many other etiologic factors. Abnormality of Renal, I already mentioned that. Temporal mandibular disorders in even in early stages, and dental caries and periodontal disease and rhinopharynx disease. This may cause oral habit, mouth breathing, or some oral habit, and trauma or cancer, bruxism, and inadequate restoration prosthesis. So temporal mandibular disorders is one possible factor to cause malocclusion. Recently, this kind of malocclusion are increasing. So this is very hard to find out in young children. Among temporal mandibular disorders, Tmjoa, joint arthritis, is a degenerative disease to cause the resorption of the mandibular condyle. This causes the retruded mandible and also mandibular deviation by cartilage breakdown. And then this is an old case, but we can see the posterior rotated mandible, mandibular shift, or anterior open bite. This malocclusion can be caused even in young children, 10 to 12 years old.
Sorry, Prof. You have 10 minutes left.
Okay. So this is one case. Actually, she was 16 years old, 12 years old when she arrived at our clinic. And when she was 16 years old, she already finished the second stage orthodontic treatment with brace, and she has perfect class 1 occlusion. But 4 years later, so she had severe open bite due to the temporal mandibular joint disorders. This can be caused early teens also. And periodontal disease, this is also the adult case, never seen in young children. But some periodontal disease cause also malocclusion, severe malocclusion. We have to think about the prevention of periodontal disease in an early stage also. And molars and abnormal tooth eruption. So even in permanent dentition, it may cause, this is actually second molar, cause open bite or some crowding in the dentition. This is all of the, I finished all slides a little bit earlier than the time. Thank you very much for your attention.
Yeah, thank you very much, Prof. Kotaro Tanimoto, for the such informative and interesting presentation. Now we maybe have several times for no question yet. Yeah. Oh, okay. From Levina. A question from Levina. Good morning, Prof. Tanimoto. Thank you for the wonderful presentation. One with impacted canines with central incisor root resorption. What was the treatment for central incisor root resorption in this case?
Thank you very much for your question. Actually, the root resorption of so we shouldn't do any orthodontic treatment in such a case. She already had braces, but it's not good to start orthodontic treatment. So when she came here, our clinic, we removed all appliances first, and to release any pressure to teeth, and also. Occlusion is very important between the lower and upper incisors to remove any the pressure from the. And to the patient, we have to talk a lot about the situation and fix all incisors by temporal how to allocate it? Small wires. By small wires, we have to have the fixation of the incisors. But for resolved now, just wait for the stop the continuous root resorption. No treatment.
Oh, so okay. No treatment, yeah. Only prepare the space, yeah.
Yeah.
Oh, okay. Thank you very much, Professor. To prevent more severe malocclusion, we can do interceptive orthodontics, or we call early treatment. Is that right, Prof? Yeah, early treatment. When is the best time for early orthodontic treatment?
For what kind of malocclusions for this early treatment? For probably for first phase treatment, usually the starting of eruption of permanent tooth, like central incisors or first molars. This is the best time for starting orthodontic treatment in many cases. But in small cases, primary dentition stage, we can also start treatment to remove oral habit. In case the patient had the open bite or mandibular deviation.
Next question from Maria Andisa. Hello, Prof. Tanimoto Kotaro. Thank you for your great lecture. I want to ask, do you have any tips to improve patients' compliance to wear removable appliances?
Excuse me, please let me know again.
I want to ask, do you have any tips to improve patient compliance to wear removable appliances? To encourage the patient maybe to wear the
retainers.
Wearing the
Okay.
Yeah.
So orthodontic treatment. Even after first phase orthodontic treatment, we need retainers to keep the good situation. And we also think about third molar eruption. During third molar eruption, in many cases, the powding or
Recording in progress.
We sometimes in pediatric dentistry we do in early age, yeah, Prof. So can you explain what is the benefit early treatment and late treatment maybe? What the benefit is?
Okay, early treatment means that in primary or mixed dension stage, right? Okay, so if we started orthodontic treatment in after completion of permanent dentition, so in many cases we have to we can't do anything for skeletal discrepancy. Our choice can be only surgical treatment. So to prevent surgical treatment, we can do something to improve the skeletal discrepancy during primary or mixed dentation stage, and also for removal or oral habit. So in many cases, it is very hard to remove the oral habit for adult. In children, it's much easier to eliminate the oral habit. This is the second reason. And also, first phase of early orthodontic treatment make the orthodontic treatment easier if we remove some critical factors to cause also malocclusion, like oral habit or the crossbite. Maybe this kind of malocclusion or oral habit cause further skeletal discrepancy. It makes orthodontic treatment much more difficult. This is why the early orthodontic treatment is very effective, but not all cases.
Yeah. Okay, thank you. Maybe other participants have questions. You can live direct deliver the question to Prof. Kotaro. Any question? Dr. Udianto, maybe Prof. Seno, Dr. Prawati, maybe you have question for this session.
Thank you, Dr. Cindy. Professor Tanimoto, how are you?
I'm good. Thank you.
Thank you so much for your lecture for today. We very enjoy your lectures. I just like to ask you about if we talking about the orthodontic treatment in children. Since we have to deal with the patients in the young age, I mean, let's say at 7 or 8, sometimes it's very difficult dealing with this their behavior. I mean, let's say if we're talking about the treatment for the bad habit, bad oral habit in children, sometimes it's not that easy. Even we are using special appliance. So can you give us some advice or maybe some trick before or maybe during the treatment concerning the behavior of the children?
Yeah.
Thank you.
Thank you very much, Sensei. So, so maybe I think it is very good at for that dentist in pediatric dentistry. So maybe our orthodontics, not so many orthodontics good at to encourage the patient, the young patient, to keep the continuous training, and usually we have tight communication with parents and also the patient, young boy and girl, to talk a lot on the school days and some holiday activities, and to have a friend, reliability each other. And also we will give some kind of treatment or trainings, and from easiest thing to difficult things, step by step. Do a lot at the same time. Step by step training is very effective, and also usage of appliances. We don't provide the several appliances at the same time. We never do like that, so one by one. So, and one successful experiments make patient more confident and more likely to cooperate to the treatment. I'm sorry, so I don't know the good the solution. This kind of case, this is very hard actually. Thank you very much.
Thank you, Professor Tanimoto.
Okay, thank you, Dr. Udi. Okay, last question from Dr. Fania. Good morning, Prof. Tanimoto. Thank you for very much. Thank you very much for the presentation. I would like to ask about I would like to ask about the temporomandibular disorder that causing the open bite in the last case. What's the treatment choice for the temporomandibular disorder and the open bite? Thank you, Prof.
Thank you very much. 谷先生、ありがとうございます。で、just that several, we have to know that several type of temperamental disorder exist. So for normal, also arthritis, so we will remove any of the excessive mechanical stress on the temporomandibular joint to remove or habit or the bruxism during the sleep. Sometimes we use the splint, but for splint is not good to use in young people, growing people, because this may affect the skeletal growth. So, but we recently worry about the idiopathic condyle resorption. This is a severe condyle resorption caused by the unknown factors. So far, we don't have any good treatment in such a case. This is only one patient in 1,000 children, very low rate disease. But so far, the only way to remove the situation is a surgery, surgical treatment in temporal mandibular joint to replace the joint disc. This may stop the rapid condylar resorption.
Okay, thank you, Prof. I think it's clear.
Cindy.
Yeah, Prof. Seno.
Gitu. Good morning, Prof.
Good morning,
Prof. How are you?
Good.
Thank you very much for your lecture today. It's very nice lecture, and I hope for the near future, I want to go Hiroshima again.
Yeah.
Awesome.
Naga,
Please.
I'm mastering this guy. How about Hiroshima now?
Yes, COVID situation getting better, but still a lot of patients still infected by COVID-19, and vaccination was also almost finished, but still new type mutated COVID-19.
Just get a good sign, eh?
ありがとうございます。
ありがとう、先生。
ありがとうございます。
Cindy, please.
Okay, thank you very much. Actually, we have still 3 questions, but time is up. Sorry for the participant. Yeah, I once again say thank you for the nice lecture, Prof. Kotaro Tanimoto, and I will give applause for our speaker today, Professor Tanimoto. Thank you very much, Prof. Yeah, I will return the session, the next session to the Master of Ceremony. Thank you.
I'm sorry, Dr. Cindy.
Yeah.
Can you remind us about the next lecture of Professor Tanimoto?
Okay. Professor Taro Tanimoto will have a presentation in 28th May. Yeah. So I hope all the participants can join for the next seminar from Kotaro Tanimoto.
At the same time.
Yeah. Same time.
From 9 o'clock in Indonesian time. Okay.
Yeah,
okay.
Yeah. Okay. And in 28th of May.
28.
Okay. Thank you, Prof. Kotaro Tanimoto. Thank you, Dr. Rudy. Yeah. I will return to the Master of Ceremony, Dr. Carissa.
Thank you, Professor Tanimoto Kotaro and Dr. Cindy for a wonderful session. We also would like to give a digital certificate of appreciation to Professor Tanimoto Kotaro, DDS, PhD, that he has been willingly to give a lecture and be our amazing today's speaker. And also to our moderator, Dr. Cindy Cornelia Nelwan, DDS, Specialist of Pediatric Dentistry Consultant, for guiding through the session. The certificate will be handed over by the Dean of Faculty of Dental Medicine, Universitas Airlangga, Dr. Agung Sosiawan, DDS, Master of Public Health, Master of Law. May I request Dr. Agung to give the certificate as an appreciation to Professor.
Good morning, Professor Tanimoto. Nice to see you again in this. Professor Tanimoto, I would like to personally thank to you for your presentation in our Stovit online series today. It's such an interesting presentation, I think. Please accept our sincere appreciation for the outstanding presentation you made with this certificate. Thank you so much for sharing your time and experiences with us. We are very honored if Professor Tanimoto and Hiroshima University will continue this collaboration. Once again, thank you. Thank you, Professor Tanimoto. We were pleased to have your participation in this webinar, and we thank you for your valuable contribution. And for Dr. Cindy as moderator, thank you so much for organizing the session very well and keeping things under control and reasonable on time. Please accept this certificate of appreciation Thank you very much. Thank you once again,
Thank you.
Professor Tanimoto. See
Thank you very
you
much. See
in the
you.
next occasion, I think.
Thank you, Dr. Agung, and thank you, Professor Tanimoto Kotaro. To Professor Tanimoto Kotaro, please feel free to tune in until the last as we will have photo session together at the end of this event. Okay, now we move on to the second lecture. For the second lecture, we have Professor Cheng Wee Ming, PhD, from the Department of Physiology in University Malaya Center, Malaysia, with the topic Autonomic Neural Homeostasis in Cardiovascular Physiology. And this session will be moderated by Dr. Aksa Shuhada Oki, DMD MS. And dear colleagues, first, please allow me to introduce our moderator for the second session. Dr. Aksa Shuhada Oki, DMD MS, as Associate Professor at the Department of Oral Biology in Faculty of Dental Medicine, Universitas Erlangga. He has got Master of Medical Physiology, Universitas Erlangga in 2001, and previously had Dental Medical Doctor or DMD in 1993, and also Bachelor of Dental Science or BDS from Universitas Erlangga in 1992. He has wealth of interest in sports science, in oral health, and also e-learning development for supporting digital education. And also, he has at least 26 journal articles that has published in last 5 years. Okay, good morning, Dr. Aksa. How are you today, Doc?
Good morning, Dr. Carissa. Fine.
Okay, thank you. All right then, without any further ado, let us proceed to the session. Dr. Aksa, the time is all yours.
Okay, thank you, Dr. Carissa. Thank you, everybody. Welcome to the session 2 in Stovit online meeting. I'm happily announcing that the Faculty of Dentistry, Universitas Erlangga organized a very interesting interactive lecture by inviting global reputation guest lecturer in medical physiology, Professor Dr. Cheng Wee Ming from the Department of Physiology, Faculty of Medicine, University of Malaya in Kuala Lumpur, Malaysia. Professor Cheng is a remarkable physiologist who has been invited to share his knowledge in many countries. He also has been a visiting professor in many universities in Indonesia. Also, Professor Cheng gives his lecture in every semester in our faculty. We can see from his curriculum vitae, we can see that the Professor Cheng has performed impressive achievement in the field of medical physiology. He completed all his academic degree in the University of Liverpool in UK, and during his career, he published a large number of articles and books. Ladies and gentlemen, just because we have a very limited time in this session, I happily invite Professor Cheng to start his lecture in about 50 minutes. Professor Cheng, are you ready?
Yes, thank you, Dr. Aksa.
Okay, Professor Cheng, the time is yours.
Thank you very much. So let me just start with sharing screen. Can my slide be seen? Okay.
Okay, Professor Cheng.
Yeah. Right. Thank you, Dean, Professor Agung Susiawan, and Dr. Aksa, and thank you, Chair Lady, Dr. Carissa, for giving me this time again to speak to your students. I spoke to your students about 1 year ago on a similar topic, and this year I'll be speaking to the juniors and with some modified slides on this topic of cardiovascular regulation, in particular with a focus on the autonomic nervous system and specifically directing on the sympathetic autonomic system because of its more major role in cardiovascular physiology. So this is the very long-sounding title. Basically, in physiology, we are always interested in homeostasis, control regulation, and today we look at the autonomic nervous system. Yeah. So there's always a question with dental students about how much of physiology do we need in our dental profession. So I'm just going to run through some essentials of blood pressure regulation and hope that this would be useful in your practice, dental practice, and in your future career. So the second slide is one I showed last year. These are some groups of dental students that I met, including some Hendra here, and who actually are your seniors, graduating seniors in Airlangga. And the other students, those in in yellow jackets, belongs to other dental schools in Indonesia. So this is taken in University Malaya, where they came for our annual dental physiology competition. So one of the main purpose of the annual dental physiology competition is obviously to try to see how we can make physiology more relevant and engaging for the dental students. And this quiz was postponed 1 year because of Corona, but last year we had the first online dental quiz, and I'm sure this year there will be a dental physiology quiz. Not sure whether we can resume the physical quiz, but anyway, this is the event. Yeah. So I'm going to first mention some hormones which will be integrated in the later slides. And these are the 4 major types of hormones that you see in the body. In particular today, as we look at the blood pressure in cardiovascular physiology, we will be looking at a peptide, a small peptide less than 10 amino acid, angiotensin 2, and the neurohormone from the posterior pituitary, ADH, and then 2 steroid hormone. One is aldosterone and cortisol, and obviously this is more familiar, adrenaline from the adrenal medulla that is stimulated by the autonomic sympathetic system. So, and as I did last year, I tried to involve some students in my presentation to provide a point of engagement between the audience, the classmates. And so I met with them. This year we had a quite short time to prepare, just a few days ago, but I think they have done something which I hope you will enjoy watching. One group is just a few minutes of looking at parasympathetic autonomic system, and then later on in my presentation, another group of students will present something on the autonomic sympathetic system. So before they come up, let me just mention one more thing. So the cardiac pump is a rhythmic pump. It's not like the pump that supplies the water to your house. It has to relax and then top up and then pump again. So it is a fixed, closed system of a fixed volume. So the cardiac pump has to relax. And so there's an interesting question. How does a rhythmic pump maintain a continuous flow to the tissue? Because during relaxation, the pressure in the ventricle is actually 0 because it has to be topped up. But blood continues to flow to the rest of the circulation and obviously to the brain and so on. So the answer I just give here is that during relaxation, which is during diastole, this is when your arteries, the aorta and the large arteries, begin to recoil because it is an elastic structure. It's not like your water pipe, which is rigid. So during systole contraction, it is stretched. And then during diastole, although the pressure in the ventricle is 0, the arterial elastic recoil is the one that contributes to what is known as the diastolic blood pressure that continues to provide blood flow to the rest of the circulation. So with that as an initial essential statement. Let's move to look at, okay, so these are some of your students and some of your classmates. I think I've got their name correct. This is Hayuro here, and Tiara, Tasha, and Dinda. So they're going to present just a few minutes on something related to the parasympathetic autonomic nervous system. So at this point, I'll stop sharing and they will present what they have. Yeah. Please.
Okay, thank you, Professor. Good morning, professors, doctors, my dear friends and guests. Today, I would like to introduce myself. The name is Hario, and I'm here not just by myself, but also Tasha is here, Tiara and Dita, and also Dinda. We are here to show you something that we have made beforehand and creatively explain to you about the function of parasympathetic nervous system. So, let's get into it, shall we?
Hi everyone, my name is the Parasympathetic Nervous System, and today I'm going to take you along my daily activity. For that, I'm going to ask the help of my friends to take you along and explain what I do on my daily life. Let's take a look.
Hello there, I'm the eye. Usually, the parasympathetic nervous system helps me to constrict my people when needed.
Hi, we meet again. So, I'm the tongue. And a little fun fact about me, the parasympathetic nervous system always helps me to stimulate my saliva flow.
Hi, my name is Lungs. In my life, sometimes my bronchi constrict when I'm sick. This is where parasympathetic nervous system comes in and helps to regulate my bronchial constriction.
Hi everyone, it's me again, the heart. Sometimes the body also needs me to slow down my heartbeat. And parasympathetic nervous system always helps me to slow it down. Thanks a lot, parasympathetic nervous system.
Hello everyone, you can call me gaster or stomach. Usually I need to do peristaltic move and secrete my gastric juice. Sadly, I couldn't do it without being stimulated first. But then parasympathetic nervous system comes along and always helps to stimulate me.
Hello everyone, my name is the liver. I often need to release bile juice, but with the parasympathetic nervous system, I cannot do it. Thankfully, she's always helping me to release bile juice. Thank you, parasympathetic nervous system. You're the best.
Hi, you're back with the parasympathetic nervous system. I hope my friends explain it to you really well, and I hope you understand on how I function in my daily life. That's it for today, and I hope we see you again real soon. Bye-bye.
Okay, thank you. So let me go back to my slide. Okay, so the students have given a very broad overview of the parasympathetic, and obviously our interest this morning is on the role of the sympathetic as well as the parasympathetic in the homeostatic control of cardiac and vascular function. So the next slide is a big overview. So if you look at what controls the heart rate, it's obviously the pacemaker at the sinoatrial node. And we often talk about that when we think about the autonomic nervous system, there is often a dual autonomic control. So in this case, the sympathetic will increase the activity of the pacemaker and increase heart rate. Whereas the parasympathetic, as the student mentions, will slow down the pacemaker activity of the SA node. And so sympathetic causes tachycardia and parasympathetic will cause a bradycardia. So this is a direct response. And very often when sympathetic increase, parasympathetic will also decrease. So there is a dual control. But when you come to the cardiac ventricles, at least in the human heart, you find that there is only sympathetic innervation. So there is no parasympathetic innervation. And I suppose if you think about what is needed in daily life, you don't want to decrease the contraction of the ventricle. You want to maintain as well as to increase it during exercise. And so if for the ventricles, it is only sympathetic nerves, and this acts on the beta adrenergic receptors. Now, when you come to the arterioles, which is the major site where the radius of the blood vessels are controlled in order to regulate blood flow to the organs, again, you find that except for one or two organs, most of the time, the arterioles are also mainly regulated only by the sympathetic vasoconstrictor system. So if you have more sympathetic, you get vasoconstriction. If you want to have vasodilation, you just reduce the sympathetic vasoconstrictor activity. So again, this is a monocontrol, and in this case, the neurotransmitter from the sympathetic nerve acts on the alpha receptors on the arterioles. Okay, so this is a big overview. So let me move on to my next slide. So this is the pressure profile as you look at the overall cardiovascular system running from the aorta on the left to the arteries, the arterioles, which we just mentioned, the capillaries, and then the venous, the veins, vena cava, and right back into the right heart. Okay, so as we know quite well, at the initial part, there is this pulsatal, rhythmic, cyclical systolic blood pressure and the diastolic blood pressure. And as I mentioned in the first few slides, the diastolic blood pressure is contributed by the arterial elastic recoil that maintains a continuous blood flow to the rest of the circulation, even though during diastole, your ventricular pressure is actually close to zero. Okay, so you can have a continuous blood flow to the rest of the body. And by the time you reach the arterioles, where you get the major site of vascular resistance, so now the pulsatal flow is more laminar. You find that there is a sharp drop in the pressure, and then a gradual decrease as you go to the veins and back into the vena cava. Okay, so there is a gradient going from the left side of the heart to the right side of the heart in the overall systemic circulation. Now, I'm going to come to this point again. So when we're talking about the arterioles, where you have the major vasoconstrictor sympathetic nerves, any action on the arterioles causes two different kinds of effects. One, we call it the upstream effect, meaning that if you constrict the arterioles, vasoconstriction, you always get an increase in the blood pressure, which is an upstream effect. It's like a river, okay? Whereas downstream, we will come to this important effect in a short while. Downstream, the same vasoconstriction of the arterioles will always reduce, in this case, the capillary hydrostatic pressure. Okay, so keep this in mind as we come to the more detailed aspect of blood pressure control in a short while. Okay? So let me move on. So back to basics. This is one of the major essential relationship between cardiac output and total peripheral resistance, and how the product of these two determinants, cardiac output and TPR, contributes to the maintenance of arterial blood pressure. So in the next slide, I'm going to just quickly remind the students that this equation actually is derived from the basic hemodynamics formula, which is flow equal to pressure over resistance. So this basic hemodynamic equation applies obviously to a single tube, a single blood vessel. But if you apply the F equal to P over R to the entire systemic circulation, you derive this BP, blood pressure, equal to cardiac output times TPR. So let me explain this quickly. So this is what I mean. This is the essential relationship. Cardiac output and total peripheral resistance are the two determinants that affects the blood pressure. And this is the equation here for a single blood vessel. Now, if you think about the overall systemic circulation going from the left side to the right side, now the flow becomes the cardiac output.
cardiac output by definition is the volume of blood flow per minute that is pumped out by the left ventricle, okay, or the right ventricle. The whole thing is a closed circuit. And then the pressure here, the driving pressure here, becomes the mean arterial pressure, okay? Because if you remember from the pressure profile graph, the pressure in the right ventricle is close to zero. So this pressure here on the left side is basically close to your aortic blood pressure or the mean arterial pressure. And now the vascular resistance that applies to the single blood vessel becomes the overall total peripheral resistance. Okay, so F is P over R, becomes cardiac output is mean arterial pressure over the total peripheral resistance. And so when you rearrange this equation, you derive BP is CO times TPR. Okay, and just to note that when we talk about the pulmonary circulation, strictly defined, it is considered separately in respiratory physiology and is not part of the systemic circulation. Okay, so let's move on. This is for your interest, those of you who have some Chinese background. This looks like the Chinese character for the heart. Okay, and so if you look at what this picture symbolizes, you will realize that actually this looks like the ventricle, right ventricle, left ventricle, and this actually could represent your cardiac output, and this one here could represent what is known as the venous return. Okay, so the venous return and the cardiac output are equal in value because we're talking about closed circulatory loop. Let's move on. Okay, so back to this equation, blood pressure is cardiac output times total peripheral resistance. Now this cardiac output, I think the students will also know that there are two components, two determinants of cardiac output. One is your heart rate and the other one is something known as the stroke volume. The volume of blood pumped out per contraction by the ventricle. Now I want to just highlight here that in terms of muscle physiology, we actually involve all three types of muscle when we think about the physiology of the cardiovascular system. The first type of muscle is obviously cardiac muscle. Okay. Now the second type of muscle, which obviously involves the blood vessel, will be your smooth muscle. Okay. So vasoconstriction of the smooth muscle by the sympathetic vasoconstrictor nerve contributes to the total peripheral resistance. Contraction of the cardiac muscle obviously contribute to the cardiac function. And this one here looks obviously like the skeletal muscle, which I'm going to mention in a short while. The skeletal muscle contraction also contributes to cardiac function. You may ask, how can that be? How does the muscle contraction activity affects the cardiac function? So this is the next slide. So this is the schematic diagram of the muscle, and you shown between the muscle layers is obviously your veins. Okay, so every time you exercise and when your muscle contracts, you have what is known as a mechanical skeletal pump that provides a greater return of the venous blood back into the heart. So this is called increased venous return. So what we're saying is that every time you exercise, you actually promote the return of the fixed volume of blood back into the ventricle chamber. And so as you fill the ventricles with more blood, the ventricles will also be stretched to a greater tension and the ventricles will pump a greater volume of blood. So this relationship between filling of the ventricles by a greater volume and the generation of a greater stroke volume because of the greater tension is known as Starling's law of the heart, described by Ernest Starling. Okay? More venous return, and in this case, this can be contributed by the muscle, skeletal, mechanical contraction that reduces the venous reservoir volume. And so this is a relationship between venous return, ventricular filling, and stroke volume, known as the the Frank Starling law of the heart. Okay? So now the other way in which you can get an increased venous return, going back to today's topic about the autonomic nervous system, is that the veins are also supplied by the sympathetic nerves. And so we talk about vasoconstriction, and normally when we use the word vasoconstriction, we think mainly about the arterioles, the arterial side. But the veins can also be constricted by the sympathetic nerves. And so we use the word venoconstriction. So every time you get a venoconstriction, and that happens during exercise when you have increased sympathetic, you also contribute to the same effect in increasing the venous return back to the ventricles. Okay, sympathetic venoconstriction also increases venous return back into the ventricles. And so venoconstriction indirectly also contributes to a greater cardiac output by the ventricles. Okay, so now at this point, I'm going to ask, I think, the next group of students to tell us something about the sympathetic autonomic system, a broad picture, before I look into more details about the sympathetic role in cardiac function, specifically on arterial blood pressure. Okay? So here we are. So this group of students, another four, Zanira here, Adisti, Anugrah, and the other Tiara. Okay, please welcome them now.
Okay, thank you so much, Professor Cheng, for giving us the opportunity. Good morning, doctors, professors, fellow friends, seniors, and guests. If I may, I would like to introduce myself. I'm Zanira, and as a team, I'm not alone here. I'm with Adisti, Anugrah, and Tiara Latifa also. And we would like to share with you our self-made video that maybe would help explain a bit about the function of the sympathetic nervous system on our body in a more creative way. So I hope you'll enjoy, and let's get started.
Hello everyone, welcome to my daily life. My name is Sympathetic Nervous System. Want to know what I do daily? Let's listen to a few of my friends spilling some facts.
Oh hey, I'm Di. Usually, the sympathetic nervous system helps me to dilate my pupil when needed.
Hello, I'm the tongue. Did you know that sympathetic nervous system always helps me to inhibit my salivation? Well, now you know.
Hello, my name is Lang, and for daily life, I need to relax my bronchi when my body needs it. And guess what? Sympathetic nervous system always helps me to relax my bronchi, and she's really good with that.
Hi everyone, my name is the heart. Sometimes the body needs me to accelerate my heartbeat, and sympathetic nervous system always helps me to do it. Thank you, sympathetic nervous system.
Hello everyone, you can call me gaster or stomach. Usually I need to tune down my peristaltic move and my gastric secretions a bit. I couldn't do it alone, and let me tell you, sympathetic nervous system is always generous at helping me. I'm so thankful for that.
Hi, my name is the liver. I often need to produce glucose and release it. But without sympathetic nervous system to stimulate me, I cannot do it. Thankfully, she's always there to help me.
Hi guys, you're back again with Sympathetic Nervous System right now. Wow, after listening to a few of my friends, I think I am kind of helpful around the body, right? Thank you for watching guys, I'll see you again.
Okay, thank you, our four students there. So the rest of this talk we now enter into a more complex and hopefully more interesting focus on the detailed sympathetic role in the control of the arterial blood pressure, which also involves the kidneys, which the students have not included because of the limited time presentation. Let me go back to this presentation now. Okay, so what we have here is a kind of diagram that we recently published. This is a combination of physiology, and obviously this is a triangle, this is a geometry. So we have called this a phi geometric diagram. Okay, so this is a phi geometric diagram linking the sympathetic nervous system to the hormonal system, which is the adrenal medulla. So what we are saying here is that in terms of cardiac function, obviously the SA node increases or heart rate, and the ventricles contributes to the stroke volume. So you have obviously a direct stimulation of sympathetic to the SA node to increase heart rate. You also have a direct stimulation of the sympathetic to the beta receptors in the ventricles to increase your stroke volume. But every time you have increased sympathetic, there is another way in which the SA node activity and the ventricular pump is increased. And this is through the secretion of adrenaline, which is also increased by sympathetic. So this is a direct effect. This is the indirect effect. And so the whole system is sometimes known as the sympatho-adrenal medullary system. Okay, so during exercise, when you get increased sympathetic, you always get increased adrenaline because the sympathetic will at the same time release adrenaline from the adrenal medulla. Okay, let's move on. So how do we understand the short-term and the long-term control of blood pressure? Now, just to mention to the students that when you hear this in the lecture, it is basically for convenience because the short-term and the long-term control of blood pressure are not two separate things. Because generally, the short-term is described under cardiovascular system, and then perhaps 2 months later, the long-term control of blood pressure is described under the renal system. And so quite often for my own students, it's partly the fault of the curriculum, the way the timetable is arranged. Students fail to understand that the short-term and the long-term control of blood pressure are actually overlapping. Okay, they are not separate events. So let me explain what we mean by this. So here we are again, back to the basic equation that we've established. Blood pressure is cardiac output times total peripheral resistance. And within cardiac output, you have the heart rate and the stroke volume. So here, this determinant here is a function of the heart muscles. This determinant here, as we said, is a function of the smooth muscle of mainly of the arterioles that are supplied by your sympathetic vasoconstrictor nerve. So under blood pressure control, the short term actually means very rapid response should your blood pressure drop. Okay, and so this involves something known as the pressure sensors. When the sensors that detects the drop in the pressure, that's why we call them baroreceptor, and you trigger a baroreflex. And once the baroreflex is triggered, you get a main compensatory response that involves the sympathetic nerves. And so these sympathetic nerves, once it is activated by the baroreflex, will go to the heart to increase heart rate, will go to the ventricles to increase stroke volume, and at the same time will also go increase to the blood vessel to increase vasoconstriction. And all these three action obviously will help to restore the blood pressure. Okay, so blood pressure drop triggers baroreflex, sympathetic compensatory action is triggered, increase heart rate, increase the stroke volume, increase the TPR. And just to remind you, what we mentioned is that at the same time, the sympathetic also increases constriction of the veins, the venoconstriction. You remember we mentioned about Starling's mechanism of the heart. The venoconstriction also contributes to a greater venous return, and that also improves the cardiac output. Okay. Now, when we talk about long term, this is where we come to the area of the kidney. So if you like English pun, this sounds like Disneyland. It's actually kidney land. So the kidneys they are very important in maintaining blood volume. Okay, and this is because the kidney restores and maintains something known as the sodium balance. So if you have done your body fluid physiology, you will remember that sodium balance affects blood volume. So indirectly, the kidneys by maintaining sodium balance is helping to maintain blood volume. And of course, blood volume then affects blood pressure. So it's a very indirect but very effective way in which the kidneys help to maintain blood volume and blood pressure. Now, why is it called long-term? It's because if you, for example, donate a volume of blood, okay, so obviously your blood pressure drop and you get a barrel reflex, but it will take a longer time for your body, together with your kidneys, to restore the absolute blood volume. It is not a rapid neural mechanism. It involves a series of hormones that we will be talking about in a short while, okay? And that is why it's called long-term. I'm going to show you, as I said, that the short-term and the long-term are not separate, segmented events. They are interrelated, okay? So let's move on. So here we are again. This is another Phi geometric diagram to remind the student that the sodium balance, which is controlled by the kidney, affects the volume of the extracellular fluid, and the blood volume is a component of the extracellular fluid volume. And once the sodium balance is maintained, you maintain the blood volume. At the same time, you also maintain the blood pressure, because blood volume and blood pressure are both related. So renal control of blood volume operates via regulating the sodium balance, as total body sodium is the main determinant of the extracellular fluid, and this also means the blood volume. Okay, blood volume is a component of the ECF, and this involves. It takes a longer time to try to activate and trigger this series of hormone known as the Renin, Angiotensin, Aldosterone system. So if you have not done your endocrine, just to highlight that this final hormone, which is a steroid hormone, aldosterone, is the one that will increase sodium reabsorption by the kidney. And so every time you lose blood volume, you enter into what is known as a negative sodium balance. And so in order to restore the blood volume, you first need to restore the sodium balance. And this is the role of the renin, angiotensin, aldosterone system. Okay, so activation of this RAS always serves to conserve sodium in order to restore sodium balance and blood volume. Okay, now this is the link. Now this focus on this word. Now this is the link between our attention this morning on the autonomic nervous system, in particular the sympathetic nervous system that supplies the kidney, and the increase in secretion of this first hormone from the kidney called renin. So if I go back 2 steps, so when you have a barrel reflex, as we said, you trigger a general increase in sympathetic activity. Okay. Now within this general increase in sympathetic activities that goes to the heart, that goes to the blood vessel, that goes also to the veins, you can put another arrow indicating that this sympathetic increased activity also goes to the kidneys. And this is why I mentioned here that the renal sympathetic activity, which is increased as a result of the barrel reflex, begins to stimulate the renin secretion. So this is the link, the overlap between the short term and the long term. Once renin starts to be increased, you get an activation that produces finally aldosterone, which will recover the needed sodium in order to restore the blood volume. So let's move on. Okay, now this is a bit complex, but I'm going to, as I mentioned this in each of my talk, I will make available this set of PowerPoint to Dr. Aksa, and then he can share it with you. So don't be too anxious about copying the details of this. This is just to show you that the renin, angiotensin, aldosterone system, which is always activated when you want to conserve volume. So you start here. If you have decreased blood volume, you find that you always activate aldosterone through this pathway, okay? And then aldosterone will increase sodium reabsorption. Now, I just want to put this up here for the sake of completeness, because we've already done the first pathway for increasing renin, which is the renal sympathetic nerve. And this one is activated by the baroreflex, the link between short-term and long-term. Now, the other two, once you have done your renal physiology, it becomes a little bit clearer, is something known as the Macula Densa mechanism, MACD. Okay, MACD is the Macula Densa mechanism. At the same time, you also trigger this mechanism, which also releases renin. And then there's an additional pathway which involves a direct sensing of the change in the renal perfusion pressure. Actually, you can change this to R. The renal arterial pressure is the same as the renal perfusion pressure, because it is the pressure that perfuses or drives the blood flow. So the kidney has sensors that detects the drop in the pressure, and that can directly also release renin. So 3 pathways to release renin, but our focus this morning is on the role of the sympathetic nerve that is activated by the baroreflex, okay, and that releases renin. So let's move on. Okay, so this is another way to appreciate. So here we go back to BP is CO times TPR. So the focus here is on this purple one here, cardiac output. Cardiac output is obviously affected by your blood volume. And when you think about blood volume, just to remind you, you need to think about the kidney, okay? And so the volume of the blood is affected by your sodium balance. And then indirectly, if the kidney can maintain sodium balance, it can maintain blood volume. The kidney, in this way, indirectly is affecting your cardiac output. Okay? Because the cardiac output determinant is affected by volume, which is affected by kidney function that regulates sodium balance. Okay, so this is the in font size almost 40 short-term and long-term mechanisms of blood pressure regulation and compensation are not sequential separate events. The neuro-hormonal mechanisms are integrated. And when we talk about neuro here, our focus today is obviously on the autonomic sympathetic system. So I'm going to mention now a little bit about what is sometimes known as the intermediate term. You have short term, long term, and now you have intermediate term. And this is where we look at the role of the capillaries in helping to maintain blood volume when blood volume drops. Okay, okay, this is just, this was given, I think soon after Chinese New Year last year. So this is to show you that we need to have an integrated picture when we learn physiology, not a fragmented, segmented picture. Okay, here we are, sympathetic, rapid, short term, we mentioned. Long term is the volume and sodium balance. Now, there is something very interesting at the level of the microcirculation or the capillary, which is known as a transcapillary fluid shift. Okay, so at the same time, you have your rapid short term and the long term, which is progressing by the renin, angiotensin, aldosterone system. Something is happening at the capillary that also helps to preserve your blood volume. Okay, and this involves sympathetic action that acts on the arterioles. Okay, now let me explain how this works. So, this tool was given to me. I was at the conference, dental conference in Indonesia, where they had some friendly competition, and so one of the students gave me this model of a tooth, so which now sits on my table. So this represents the capillary. ISF is interstitial fluid. This is vascular volume inside. The pi C is the oncotic pressure, the osmotic pressure, which is contributed by the plasma protein. PC is your hydrostatic pressure in the capillary. Okay, so imagine that you have a barrel reflex being activated. So one of the things that happen is that you get increased sympathetic to the arterioles to cause vasoconstriction, right? Now, remember I said there's an upstream effect and there's a downstream effect, okay? Now, the upstream effect of sympathetic vasoconstriction is obviously to try to restore the blood pressure upstream here. But at the same time, there is an effort to compensate by increasing the blood pressure upstream. Downstream, beyond, this is like a river downstream, the hydrostatic pressure, which is PC, actually drops every time you have a vasoconstriction. Now, what this means is that now the balance of the forces, I'm not sure whether you've done something known as the Starling's forces at the capillary. So now the balance of the forces shift, because normally the hydrostatic pressure promotes filtration, the oncotic pressure promotes reabsorption. Now that the hydrostatic pressure downstream has dropped, but there is still no change in the oncotic osmotic pressure that promotes reabsorption, you will find that there will be a greater net reabsorption of fluid from the interstitial fluid back into the vascular volume. So that is why this is called transcapillary fluid shift from the ISF into the vascular volume. So this is just a temporary measure in order to compensate for the drop in the blood volume. So before the kidney, which will take a longer time, restore the sodium and the actual blood volume. Okay, so this is an intermediate way in which compensation can occur. And again, you find that the sympathetic nervous system is again involved. So again, the short term involves sympathetic, the intermediate term involves sympathetic, the long term also involves the renal sympathetic nerves. Everything is integrated. Okay. So now let me just mention something just to make a major point. The central homeostatic vasoconstrictor response, and this will involve your sympathetic activity, is complemented by, at the same time, some local vasodilation in order to ensure adequate blood flow to the two essential organs, the brain and the heart. Okay, so your sympathetic vasoconstriction, as a result of the barrel reflex, the purpose is to maintain the blood pressure, but at the same time, at the local tissue, especially in the heart and in the brain, you get at the same time a vasodilation. So both actually contributes to maintaining sufficient blood flow to the brain and heart. Okay, you try to raise the blood pressure, the driving pressure, and then at the brain and the heart, you vasodilate. So both actually benefits these two essential organs. Okay? So this is just to engage the student. Because one of the main purpose of blood pressure regulation is obviously to maintain blood pressure, blood flow, the brain. This is cerebral circulation. Okay, so if you think about the giraffe, its blood pressure regulation must be very efficient because it's a very long neck. Okay, there's a greater distance to pump sufficient blood flow to the brain of the giraffe. Okay, so perhaps your colleague in the vet school will be able to tell you more about this. Okay, so this is what I've just mentioned. The brain and the heart always tries to auto-regulate their blood flow. And so when we talk about the total peripheral resistance, this will increase when you have a sympathetic vasoconstriction. But obviously, if you think logically, the brain and the heart, the arterioles, are not part of this compensatory increase in TPR. Because if it is, then you will make the blood flow reduction even more. Okay, so this is from the same book. So this is just to highlight again in this physiometric diagram that the central barrel reflex occurs at the same time as the local vasodilation because of the vasodilator metabolite in order to ensure that the blood flow, in this case, to the cardiac muscles are sufficient. Okay, so this is the central sympathetic response. This is the local metabolite vasodilator response, which together maintains, helps to maintain adequate blood flow to the heart. And if you change the cardiac cells to your neurons in the brain, the diagram also would be correct. Okay. So let's move on. So again, I like to doodle. So our focus this morning is on the autonomic sympathetic nervous system in particular. So here is what I just mentioned. The adrenal medulla secretes adrenaline, which affects the heart rate and the stroke volume. And remember, we said that this is the sympathetic activity, part of the sympatho-adrenal-medullary system. Okay, so this is one pathway. This one here, now this JG cells, I don't want to give too many names. These JG cells are the cells in the kidney that secretes renin. So remember I said that the one lying in black is your renal sympathetic nerve. Every time you get an increase in sympathetic activity, the renal sympathetic nerve is also increased, and this causes increased secretion of renin that then produces angiotensin 2, and angiotensin 2 then stimulates aldosterone. Okay. Now, if you look at the role of aldosterone, this is obviously involved in sodium balance and blood volume control. Okay, so this here we have blood volume, here we have cardiac function, and then I want to mention something else for the sake of completeness, since we have this adrenal cortex. The adrenal gland also secretes a hormone, a steroid hormone called cortisol, and this is obviously under a more complex control involving the hypothalamus that releases corticotrophin releasing hormone, and then the pituitary that releases the adrenocorticotrophic hormone, and this then releases cortisol. Now, I want to fit this into cardiovascular function for this morning, is that this steroid hormone actually is very important in helping to make your blood vessel responsive to vasoactive substances. In other words, if you do not have sufficient cortisol, your any substances like your angiotensin 2 cannot sufficiently vasoconstrict your blood vessel. So the sensitivity or the vasoresponsiveness of the blood vessel requires a physiological level of this steroid hormone. Okay, so all this important. So let's move on. Okay, so let me put up the word sympathetic. This is our focus this morning. Sympathetic, and then this is adrenal medulla. To remind you, this is adrenaline, and then angiotensin 2. Now this is the afferent arteriole in the kidney. Now the afferent arteriole in the kidney is where the location of your renin is produced, your JG cell. So the JG cells is actually part of the afferent arteriole. And so to remind you that sympathetic also increases renin secretion that then leads to production of this. Okay. Now I want to just mention, because you haven't done renal physiology, and that is when you vasoconstrict your afferent arteriole, afferent arteriole is just a smooth muscle structure in the kidney. You tend to reduce the filtration of sodium. And this obviously is part of the conservation of sodium. Okay. And then the other effect of vasoconstriction of the renal afferent arteriole is that you actually contribute to the total peripheral resistance. Remember I said that some organs do not contribute to the compensatory increase in TPR, like the heart and the brain. But other organs like the kidney, when you have an increase in TPR, it definitely involves the kidney, because the afferent as well as the other arterioles, the efferent arterioles, are constricted. Okay, so the function of the afferent arteriole in the kidney is fascinating, because this is where renin is released. This is where TPR is increased. And this is also where you can reduce the filtration of the sodium. Okay. So this is a bird's eye view. This is a picture of my grandson looking out. This is to show you it's very important that you always have a big bird's eye view of the integrated physiology. So let's move on. I think we should finish with a few more slides. So I think some of you who were at my lecture, I tried to simplify this and help you to remember Ayalanga starts with the letter A. And so this morning we are looking at the autonomic nervous system, and in particular, the essential multitasking sympathetic neural activity. Okay, so this one produces adrenaline by the sympatho-adrenomedullary system. Angiotensin 2 is also produced, and this is because the sympathetic nerve can stimulate renin secretion. Okay, and then angiotensin 2 produces aldosterone, and then ADH. Just to mention that ADH is always increased when there's a drop in the blood volume. There are volume sensors that are linked to the secretion of ADH. And then what is this R? I'm trying to make it fit in. R is the sensation of thirst, your thirst sensation. Whenever you are hypovolemic, there are neurons in your hypothalamus that will increase the desire to take water. Okay, that means you drink water as long as you are still conscious. And again, this operates through the volume sensing. Every time your volume drops, you stimulate ADH, you also stimulate this group of neurons in the hypothalamus called the thirst center. And then now just to put it in red, you should draw a line here below the blue letters, because atrial natriuretic peptide is involved in the opposite situation should you get an expansion of your blood volume. Because as the name suggests, when this hormone is increased, you tend to increase both the sodium and the water excretion. This is a combination of two words, sodium and diuresis. Okay, so this obviously happens in the opposite situation when you want to reduce the excess body fluid or the excess sodium in the body. Okay, you excrete more sodium, you excrete more water. So, and at the same time, you will obviously also inhibit all these other actions. Okay? So let me just, for the sake of completeness, this is vasopressin, the other name of ADH, just to show you the pathway. As I said, when your blood volume drops, there are actually two sets of volume sensors. The baroreceptors are considered as a volume sensor because these are just pressure sensors. So when your blood volume drops, your blood pressure drops. And so the baroreceptors are actually sensing volume. Now, there's another group of volume sensing which are found in the venous side as well as in the cardiac chamber. And whenever the blood volume drops, both afferent impulses from the baroreceptor as well as afferent impulses from the volume receptor in the veins and in the cardiac chamber can actually activate ADH secretion, okay, from the posterior pituitary. And so obviously this makes sense because we want to recover the fluid that is lost. Okay, so just for the sake of completeness. So we just to give you a little bit more detail. This angiotensin 2 is a fascinating molecule, angiotensin 2. Just to digress slightly, because since we are in COVID season, the conversion of A1, you get renin, and then you get angiotensinogen, and then you get A1, and then A2. Now, the conversion of A1 to A2 obviously requires an enzyme. And one of the subtype of this enzyme, the angiotensin converting enzyme, one of the subtype is now known as the receptor for your coronavirus. This is just something, just for your information. And so obviously there must be some relationship between virus infection and this pathway. Okay, but anyway, let's look at angiotensin 2. So angiotensin 2, we just said, stimulate aldosterone secretion from the adrenal cortex. Angiotensin 2 has very similar action to the autonomic sympathetic activity, which is our focus this morning. Okay, so a lot of the action that we see sympathetic activity produce is also produced by angiotensin 2. Okay, for example, it increases the TPR. It's a vasoconstrictor. It also reduces the filtered sodium load because it vasoconstricts the afferent arteriole. Okay, and it also increases sodium reabsorption. Okay, and then angiotensin 2 also stimulate ADH secretion. This is quite fascinating, isn't it? That means the angiotensin 2, a very small peptide, enters the brain and stimulates the secretion of ADH from the posterior pituitary. And lastly, this special molecule also causes an increased sensation of thirst. Okay, we use the word dipsogenic. Anything which is a dipsogenic increases the generation of the thirst sensation from the thirst neurons in the hypothalamus. And I think this may be my last slide. Okay, so yeah, so let me put it up here as a summary. So we're talking about volume sensing, blood volume sensing, which is obviously related to blood pressure. Every time the blood volume drops, the blood pressure will drop. There's a neural reflex, which is obviously the rapid short term involving the sympathetic activity. Okay, and the sympathetic activity is activated. You have the barrel reflex. You have also the secretion of renin, and the volume sensing will also, as we just mentioned, activate ADH, activate sensation of thirst. Okay, these are the location of your volume sensing, and then in the kidney, we also mentioned that there is direct sensing of the drop in the pressure, and because these pressure sensors are found in the kidney, we call them intra-renal baroreceptor. So this is the second pathway where renin can be secreted. Remember, sympathetic activity can also increase renin. And this is the direct sensing that produces what I mentioned in the opposite situation where you have an increase in the blood volume, where you need to release atrial natriuretic peptide. Okay, so yeah, I've been reading about who is this Alanga whenever I speak to a group of students. Okay, so thank you again for the students who participated briefly to try to provide a point of engagement between myself and this junior class of year 1 students. Okay, thank you very much for listening.
Thank you very much, Professor Cheng, for the inspiring lecture. I believe your presentation gave beneficial knowledge for the students and give inspiration for us as a teacher. Ladies and gentlemen, as usual, Professor Cheng always creates enjoyable environment in the class during teaching. Then the students are happy to gain knowledge without any stress and pressure. Next, I open the Q&A sessions. The participants and students are welcome to write questions in the chat section. For the student, I hope you can ask your question for Professor Cheng. I really hope the student to give the question, because this is a very important thing for you as a future dentist. The understanding of the blood pressure knowledge is very important for you. Okay, maybe I would like to ask one question for Professor Cheng. Meanwhile, we are waiting for the student to ask. We recognize that both ADH and aldosterone give the effect for increasing blood pressure in their own ways. Based on your knowledge, which is the more powerful effect for increasing the blood pressure between ADH and aldosterone, Professor Cheng?
Yeah, the ADH is a peptide, so the response time is more rapid. And so ADH obviously is involved in volume conservation by reabsorbing water, but ADH also has receptors on the blood vessel that will increase vasoconstriction of the blood vessel. So, and I think sometimes it is used pharmacologically to increase the total peripheral resistance. Yeah. Whereas the effect of aldosterone, which is a steroid hormone, takes a longer time. Yeah. So
Okay.
it is a matter of the timeline. Yeah.
Okay. So aldosterone will give the longer, longer effect here. Okay. If any question for the student or audience, for other physiology teacher, maybe. If there is no question, to save our time, I think the time is up. Then I give back the meeting for Dr. Carissa as chair lady. Dr. Carissa, please. Thank you.
Thank you, Professor Cheng Wei Ming and Dr. Aksa for a wonderful session. We would also like to give a digital certificate of appreciation to Professor Cheng Wei Ming, PhD, that he has been willingly to give a lecture and be our amazing today's speaker. And also to our moderator, Dr. Aksa Shwadoki, DMDMS, for guiding through the session. The certificate will be handed over by the Vice Dean of Faculty of Dental Medicine, Universitas Airlangga, Dr. Andra Rizkiawan, DDS PhD, Specialist of Oral and Maxillofacial Surgery. May I request Dr. Andra to give the certificate as an appreciation?
Yes, thank you very much, Master of Ceremony. Yes, I agree with you, Professor Cheng. So you give the inspiring lecture for the student. I think for them, only for read the book, I think it's not enough. They need to virtualize what happened with the body. Yeah. Thank you very much for Professor Cheng. In this opportunity, I would like to give the certificate of appreciation to Professor Cheng Wei Ming for participating as a speaker in Stovit online series. Thank you very much, Professor Cheng.
Thank you, Prof. Andra.
And the next for the honorable moderator, my teacher, Professor Dr. Aksa Shwadaoki. Thank you very much for guide in this session. So this certificate I would like to give to Dr. Aksa Shwadaoki as a moderator in Stovit online series. Thank you very much, Dr. Oki.
Thank you. Thank you very much.
Thank you, Dr. Andra and Professor Cheng Wei Ming. Now, before we close the session, we would like to take a picture together with all participants. To all participants, please turn on your camera. Okay. Maybe to all participants, you can please turn on your camera before we together take a picture. Well, we'll capture from the first slide, and now we have 7 slides today. Okay. Maybe from the first slide. 1, 2, 3, smile. Okay, next slide. Okay, thank you very much for the group photos. Okay, now, finally, on behalf of Stovit Online Series Committee here today, once again, I would like to send my highest gratitude to our speaker, Professor Tanimoto Kotaro, DDH, PhD, and Professor Cheng Wei Ming, PhD, for taking your time to share your knowledge to us today. Thank you, Professor. We hope that we can meet you again in person for further projects. Well, thank you.
Bye.
Last but not least, thank you to all participants for joining today's seminar. Hopefully, we will meet again in the next agenda. Please to take note that to fill the attendance form that's provided in the chat box. We look forward to see all of your participation on the next Stovit online series. Wassalamualaikum warahmatullahi wabarakatuh, and good day, everyone.
Thank you, Dr. Carissa. Thank you, Prof. Cheng.
Bye-bye.
Recording stopped.